Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 496 of our pharmacotherapy series, which majors in acute kidney injury. The first case reads, ATG is a 81-year-old, 80-kilogram white male with a height of 5 feet, 10 inches, being treated for Streptococcus bovis prosthetic valve endocarditis. ATG is known to have systolic congestive heart failure with an ejection fraction of 25%. ATG has a low blood pressure at 90 systolic 50 diastolic, pulse 110 beats per minute. Since admission, ATG has received ceftriaxone 2 grams IV daily, and gentamicin 80 milligrams IV every 8 hours. Today, which is hospital day 7, significant laboratory values are as follows. ABUN of 67 milligrams per deciliter. A serum creatinine of 5.4 milligrams per deciliter. The baseline value was 0.9 milligram per deciliter. WBC count of 16,700 cells per microliter with continued left shift. FeNA of 3%. During the last 2 days, ATG's urine output has steadily declined, and today it is 700 milliliters over 24 hours. A urinalysis revealed many WBCs, 3% RBC casts, brush border cells, and granular casts with an osmolality of 250 milliosms per kilogram. A serum trough gentamicin concentration obtained with the last dose is 6 milligrams per liter. The target value is less than 1 milligram per liter. Given the history and laboratory data, what is the likely source of ATG's acute kidney injury? The source of acute kidney injury in this situation is likely multifactorial. Low renal perfusion secondary to low ejection fraction can result in prolonged renal ischemia. Second, ATG has received 1 week of gentamicin, a well-known nephrotoxic antibiotic. The latest gentamicin trough concentration of 6 mg per liter is far higher than the target value of less than 1 mg per liter for a traditional 3 times daily dosing regimen used for Synergy for bacterial endocarditis. Given the laboratory data and the clinical course of prolonged hypotension, vasopressor, and aminoglycoside administration, non-oliguric acute tubular necrosis is the most likely diagnosis. The next question reads, how does aminoglycoside-induced acute tubular necrosis present, and what are the mechanisms of toxicity? ATG illustrates the typical presentation of aminoglycoside-induced nephrotoxicity. Generally, the onset occurs after 5 to 7 days of treatment and presents as a hypoosmolar, non-oliguric renal failure with a slow rise in serum creatinine. Because of the tubular necrosis that occurs, the urinalysis is often positive for low molecular weight proteins, tubular cellular casts, epithelial cells, WBCs, and brush border cells. The mechanism of aminoglycoside-induced acute tubular necrosis is complex. Approximately 5% of filtered aminoglycoside is actively reabsorbed by the proximal tubule cells. These agents are polycationic and bind to the negatively charged brush border cells within the tubule lumen. Once attached, these agents undergo pinocytosis and enter the intracellular space, setting off complex biochemical events that result in the formation of myeloid bodies. With continued formation of myeloid bodies, the brush border cells swell and burst, releasing large concentrations of aminoglycoside and lysosomal enzymes into the tubule lumen, thereby beginning a cascade of further tubular destruction. The following rank order of nephrotoxicity has been collated from human and animal data: neomycin greater than gentamicin greater than tobramycin greater than amikacin greater than netilmycin, which is greater than streptomycin. The next question reads: is extended interval aminoglycoside dosing less nephrotoxic than multiple daily dosing regimens? Extended interval aminoglycoside dosing entails the administration of one large daily aminoglycoside dose instead of multiple daily dosing. This dosing scheme takes advantage of the concentration-dependent killing activity and post-antibiotic effect observed with aminoglycosides while minimizing time-dependent toxicity. The net effect of this dosing scheme, purportedly, is greater efficacy with reduced toxicity. Aminoglycoside nephrotoxicity is a function of drug exposure, and it might be minimized with extended interval dosing because of saturable uptake kinetics in the proximal tubule. That is, only a maximal amount of aminoglycoside is transported into the tubule cell, no matter how much aminoglycoside is present in the tubule. Consequently, once saturation occurs, the remaining aminoglycoside concentration passes through the proximal tubule without being absorbed, and is excreted in the urine. Accumulation is therefore averted. This concept is supported by studies demonstrating that continuous-rate gentamicin infusions, which produce sustained low plasma concentrations, result in greater proximal tubule uptake and nephrotoxicity than extended interval regimens. This is probably because the achieved drug concentrations are well below those required to saturate the uptake mechanism. Extended interval dosing results in very high peak concentrations to improve efficacy and generally undetectable trough concentrations before the next dose, thus minimizing accumulation. Numerous clinical trials and meta-analyses have compared the efficacy and toxicity of extended interval aminoglycoside dosing with conventional multiple daily dosing regimens. For endocarditis, aminoglycosides, such as gentamicin dosed at 1 mg per kilogram every 8 hours or 3 mg per kilogram once daily, adjusted for renal function, are recommended by the American Heart Association for the management of selected cases of bacterial endocarditis for their synergistical activity with the beta-lactams. The extended interval dosing is less well studied for endocarditis. In summary, Extended interval aminoglycoside dosing appears to result in similar or greater efficacy, with similar or reduced toxicity. This dosing schedule is also less costly when considering therapeutic drug monitoring, preparation, and administration costs. Although the typical extended interval in patients with normal renal function is dosing every 24 hours, the interval may have to be prolonged to several days in patients with renal failure. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 497.